video I'm going to show you what a hyper-angulated or D blade looks like and when to use it. So this is, multiple manufacturers actually make this, but this is a special kind of blade that will come with video laryngoscopes. This is not an option for direct laryngoscopy. So if you have video laryngoscope, one of the blades you can order is this hyper-angulated blade. So this is a standard geometry Mach 3, so you can see it's a little bit, it's kind of a gentle curve. This one has a very abrupt curve, so this is great for kind of anterior airways, and it can give you really good visualization in what could be otherwise a very difficult airway. Now, important to keep in mind that in general you're going to want to use a rigid stylet. So this stylet has this kind of inner flexible metal core that you can bend and it'll retain that shape. These rigid stylets are not meant to be bent. Don't change the angle of these or you'll wreck it. So leave that be. Now the hyperangulated blade can pretty much be used on any adult if you get comfortable with it, but there are certain populations, like again anterior airway, short necks, where these can be very beneficial. So if you're having difficulty with the standard geometry, that is one option to try. Or if you're anticipating difficulty, you can go straight to the hyperangulated blade. Alright, so now I'm ready to intubate with my hyperangulated blade. Now I'm choosing this rigid stylet to use with the hyperangulated blade because I need to be able to get it more anterior and it needs to be stiff so it doesn't bend. You can try this with a bougie, but in general you're going to use this stylet, rigid stylet. So just like with any other intubation, I'm going to make sure I'm all prepared. I'm going to gently enter the oral opening here, and I'm going to slowly advance. As I'm slowly advancing, I am not rocking the blade back like this towards the patient's teeth. If I need to get a better view, I'm going to pull up and out. Okay, that action lifts the head instead of tilting like that. I'm going to advance slowly. Now I can see the tip of the epiglottis. As I advance a little more, my cords are going to come into view. Just like that. And then I'm going to be able to pass my ET tube. Now in this case, I'm able to have a full view of those cords, and I can visualize the tube passing the cords. That's a critical component, both to know I'm in the right spot, but also to know I'm in the right depth. Okay, so I see the balloon there. I'm not deep enough yet. So the balloon is passing, and the balloon is passed. That's an overall good depth. I'm still going to verify my depth by making sure the number matches with what I would expect it to be, but also getting a good idea by being able to directly visualize. Okay?